topic is regarding nephrotoxin stewardship. I will talk about the emerging, this is a new emerging concept, nephrotoxin stewardship. Why are we talking about nephrotoxin stewardship actually? This is an article that I've picked up from critical care clinics, and it is based on a study that was done in it was published by University of Pittsburgh, actually, critical care nephrology from University of Pittsburgh. So they have actually found out that patients who are admitted in the hospital, they receive almost around 17 medications per day, approximately, about 34 medications during their ICU stay. And amongst all the medication, 10 medication approximately are considered to be high risk, which are used during their stay. So when we talk about stewardship, we need to know what stewardship is. So it is defined as conducting, supervising, or managing of something, especially the careful and responsible management of something entrusted to one's care. And whenever we talk about stewardship, the first thing that comes to our mind is antibiotic stewardship, which was defined as a set of coordinated strategies to improve the use of antimicrobial medications with the goal of enhancing patients' health outcomes, reducing resistance to antibiotics, and decreasing unnecessary cost. And that was given by the Society of Healthcare Epidemiology of America. And now here we are talking about nephrotoxin stewardship. And the reason why is acute kidney injury occurs in up to 22% of patients who are hospitalized and up to 65% of patients who are critically ill. And the drugs contribute to approximately 30% of acute kidney injury amongst these people. Most commonly used drugs that are responsible for acute kidney injury includes NSAIDs, anti-inflammatories, immunotherapies, chemotherapeutic agent, in addition to the antibiotics. And patient with unstable kidney function require medication dosing management as per renally cleared drugs. And if we do not calculate that properly, we are overdosing approximately 67% of the patients and underdosing about at least of 7.3% of the patients. So we do not have an exact definition of nephrotoxin stewardship, not mentioned in the literature as of now, but this is a proposed definition, which is a set of coordinated patient care management strategies for safe medication use and ensuring kidney health and avoiding unnecessary costs to improve the use of nephrotoxins, renally eliminated drugs, and kidney disease treatments with the goal of enhancing patient outcomes. So to carry out this nephrotoxin stewardship, there are goals that have been put forward to enhance patient outcomes, which includes medication safety, where we talk about appropriate drug dosing, like not overdosing, not underdosing, preventing or ameliorating the adverse drug events, and ensuring kidney health by, again, preventing the drug-induced acute kidney injury or acute kidney injury to chronic kidney disease patients or worsening of chronic kidney diseases, and avoiding unnecessary cost by choosing the treatment wisely, the test wisely. So we'll talk about these goals one by one. The first goal is medication safety. Here, medication errors can occur at any stage, like during prescribing the medicine, dispensing it, administration, or monitoring the medication. Unfortunately, this inappropriate prescribing with overdosing or underdosing with of renally eliminated drugs, this is the most common error that have been seen. The second thing which is which we need to take care of is drug-to-drug interactions, because approximately 13% of drug-to-drug interactions increases the risk of nephrotoxicity. So these medication errors can lead to a patient harm, which is known as adverse drug events, and lack of knowledge or lack of monitoring during changing or unstable kidney function can lead to adverse drug event, can lead to acute kidney injury. So how can we avoid this? First thing is making a standardized list of renally eliminated drugs, because approximately 19 to 67% of drug orders in patient with unstable kidney function occurs because of lack of knowledge, lack of that list. American Geriatric Society has developed Beer's criteria. This Beer's criteria actually gives us a list of drugs which should be avoided, or if given, then what care should be taken. So this is something that even we need to follow to make a list for nephrotoxins. There's another Hanlon and colleagues, they used a modified Delphi model actually to make a standardized list of medications. So again, this could guide us. Most recent published standardized list of focus on dosing requirements in primary care practices. And another thing is we need to keep on updating this drug list annually, because we keep on getting new information regarding the drugs we already know, as well as the newer drugs are added to our list. Second thing that we should take care of is therapeutic drug monitoring, especially for the drugs that are renally cleared or affected by kidney diseases. That helps us to provide individualized drug dosing to ensure optimal effectiveness and avoid toxicity or even subtherapeutic drug concentrations of those drugs which have a narrow therapeutic ranges and significant pharmacokinetic variability. And this includes drugs like aminoglycosides, digoxin, lithium, vancomycin, and even phenytoin. The second goal to nephrotoxin stewardship is kidney health. Patient care strategies are centered on prevention and amelioration of drug-induced acute kidney injury or preventing chronic kidney disease progression here. Because it has been seen that after drug-induced acute kidney injury, 70% of the patients have residual kidney damage even at 6 months. So for performing stewardship here, we require surveillance of drug-related hazardous conditions, which are known as deviations in biochemical, physiological, or clinical status caused by medications causing further injury to the kidney. So here also what we can do here is making a standardized list of nephrotoxin. This is provided in the chart as to how they propose it to create or to make that list. Like, especially this will be helpful in ICU where number of drugs used are more and the pattern that they are being used is different. And we need to update this list again annually for including the newer drugs as well as the details of the older drug. So how they propose this is they make a group, is to make a group of stakeholders for nephrotoxin stewardship committee to propose the drugs that are nephrotoxins and include the drugs that are renally cleared for this surveillance. We can classify the medication, including what class they belong to. We can assemble the literature regarding those drugs and assign the evidence grade to those drugs, discuss the evidence, and we can edit the list and finalize the list. And once the list is being finalized, they propose to communicate it to the IT department. And finally, these things need to be repeated annually. The second thing that we can do here is therapeutic drug monitoring of those nephrotoxins, as I mentioned, like aminoglycosides, vancomycin, and even calcineurin inhibitors. We need to improve the estimates of GFR for even more accurate attainment of target drug concentrations. And instead of using creatinine, we can think about using cystatin C, which is a functional biomarker that overcomes the limitation of serum creatinine because it has less interference from the co-founders like age or muscle mass. And in critically ill patients with unstable serum creatinine, eGFR based on creatinine equations are not recommended. So here we can use the kinetic eGFR for optimal medication dosing. Even aminoglycosides that are not secreted or reabsorbed, but are filtered with little non-renal clearance, Thus, decrease in aminoglycoside clearance and increase in drug concentration could be a marker, a warning for us that the patient might develop acute kidney injury. And this concept of aminoglycosides can also be applied to vancomycin in non-critically ill patients. The third thing here is pharmacokinetic drug interactions. So what is pharmacokinetic drug interaction? It is co-administration of two drugs that result in altered absorption, distribution, and elimination of one of the drugs. Critically ill patient receive approximately one drug, which is cytochrome P450 inhibitor, and the another, which is cytochrome P450 inducer during their ICU stay. And approximately 60% of critically ill patient experience drug-to-drug interaction because of the drug administration here. The example of this is clarithromycin with diltiazem. And clarithromycin with amlodipine or phenoldiphine, nifedipine, diltiazem, or verapamil. So here, clarithromycin actually inhibits the metabolism of diltiazem through cytochrome P450 enzymes and enzyme 3A4, leading to increased diltiazem concentration, thus leading to hypotension and probably contributing to ischemic kidney injury. Similarly, clarithromycin and amlodipine, phenoldiphine, nifedipine, diltiazem, or verapamil compared with azithromycin, which is a macrolide inhibitor that does not inhibit cytochrome P450 3A4 enzyme, can be used along with calcium channel blocker instead of using clarithromycin here. Other examples of this include simvastatin plus cyclosporin, or statin plus macrolides, or tacrolimus plus azole antifungals, and cyclosporin plus ciprofloxacin. The next is pharmacodynamic drug interactions. So here, the concomitant administration of two or more drugs interact to influence additive, synergistic, or antagonistic body's reaction to effects from the combination. The example here is using NSAIDs and diuretics together. So here, using NSAIDs causes vasoconstriction of the efferent arterioles, contributing to possibility of developing AKI, and diuretics are associated with the AKI because of decrease in effective blood volume. So this additive effect of NSAIDs and diuretics can potentiate the occurrence of acute kidney injury. And when the NSAIDs diuretics are used, and addition of angiotensin converting enzyme inhibitors together, all three is known as triple whammy for the kidney. Other examples include cisplatin plus aminoglycoside, clindamycin plus gentamicin. And so we need to keep monitoring these interactions and avoidance of pharmacodynamic interactions to avoid the progression of kidney injury. Next is to talk about nephrotoxin burden. So nephrotoxin burden is defined as a cumulative or aggregate exposure to nephrotoxins with consideration of nephrotoxin potential for each drug evaluated at a given time or within a reasonable time frame, depending on half-life of the drug in the body. So it is dependent on duration of drug exposure as well as the nephrotoxin potential of the drug. For example, acetaminophen is noted to be nephrotoxin in literature, but it has very low potential compared to calcineurin inhibitors, which have a very high potential. Another is co-administration of nephrotoxins is noted to be an independent risk for acute kidney injury occurrence. So careful selections of nephrotoxin must be made while using those drugs. Next is hypervigilance in early detection. So when talking about the hypervigilance of a nephrotoxin burden has been proposed in the form of nephrotoxic injury negated by just-in-time action known as NINJA program. Here, CDS alert was developed actually using the following knowledge, like greater than or equal to 3 nephrotoxins on the same day will give us an alert, or receiving intravenous aminoglycoside for more than or equal to 3 days will give us an alert, or receiving intravenous vancomycin for greater than or equal to 3 days gives us an alert. So what this does is it gives alert these times, and this alert is delivered to pharmacist. Pharmacist who will notify the patient care team, whoever is taking care of that particular patient, and thus regarding the exposure of nephrotoxin, and we can monitor daily serum creatinine level. So this Ninja program was applied, and it has resulted in 42% reduction in days of acute kidney injury per 100 days of nephrotoxin exposure. And it has been implemented in 9 sites, and that has shown a positive impact on patient outcome of approximately 24% reduction in acute kidney injury prevalence rates, and 37% reduction in AKI rates per exposure. So here damage and stress biomarkers can be used, such as kidney injury molecule 1, N-acetyl B-D-glucosamine, NAG, or neutrophil gelatinase associated lipocalin, and tissue inhibitor of metalloproteinase, and insulin-like growth factor binding protein like TIMP7 have been have a predictive value in early recognition of drug-induced acute kidney injury. So urinary NGAL effectively identified amphotericin-associated acute kidney injury 1.7 to 2.3 days sooner than using the functional biomarker like serum creatinine. Next is KIM1 and NGAL combined provided a better predictive value for vancomycin-associated acute kidney injury as compared to serum creatinine. Also, TIMP2 and IG and insulin-like growth factor binding protein 7 as an early predictor for vancomycin-associated acute kidney injury have been studied. Do the impact actually of stress-related biomarkers and hypervigilance in early detection of acute kidney injury is uncertain at this point because it is still under study, but this is something that can be used to monitor the kidney function of a patient. Apart from drugs that we have been talking about, drug-to-drug interactions and everything, the another important thing that is responsible is the susceptibilities as well as the exposures of the patient. Susceptibilities include dehydration, advanced age, female, black race, chronic kidney disease, diabetes mellitus, any carcinoma, or anemia. Exposures like sepsis, critical illness, circulatory shock, burns, trauma, cardiac surgery, or major non-cardiac surgeries, or introduction of a radiocontrast agents. So, incorporating the damage biomarkers into risk assessment can improve the discrimination for acute kidney injury, and nephrotoxin stewardship to ensure kidney health requires a comprehensive patient assessment by a multi-professional team. And third is using an evidence-based preventive strategies like when we talk about kidney injury or caused by contrast as a causative factor for drug-related event. So there's a trial that is known as PRESERVE trial, that is a prevention of serious adverse events following angiography. It was a randomized controlled study evaluating prevention strategies for contrast-associated AKI, demonstrated that there was no clinical benefit with intravenous sodium bicarbonate or intravenous sodium chloride or acetylcysteine compared to placebo. And similar with intravenous acyclovir, that nephrotoxicity occurs in 12 to 48% of the patients receiving intravenous acyclovir, especially at high doses. Because this acyclovir has a low solubility in the urine and can precipitate or crystallizes itself into renal tubules, it can lead to obstruction as well as a cellular necrosis. There is the volume depletion or rapid administration contributes to the occurrence of nephrotoxicity, and this can be prevented by low dose IV or oral administration in the presence of euvolemia and adequate hydration to be given to the patient. And drug management during acute kidney injury, like we need to continuously have a monitoring over the drug that are being administered in all the ICU, in all the settings, could be hospital, ICU, or even community. So we need to include adjusting doses of drugs that are cleared renally, avoiding nephrotoxin, or if we have to use nephrotoxin, then we need to cautiously restart them, and reaching a target treatment goals for chronic medications for diseases such as diabetes and hypertension that contributes to kidney injury. Treatment for acute kidney injury has not yet been completely developed successfully. So most of it is based on prevention and reducing the nephrotoxin burden. So many therapies are under investigations like levosimendan or aminophylline, phenoldopa, perfenidone, pentoxifylline, and various other antioxidants. The goal 3 for nephrotoxin stewardship include avoiding unnecessary cost. Nephrotoxin stewardship must be used in a cost-efficient manner. So goal 1, goal 2 can be implemented with the use of automated CDS alerts. Avoiding unnecessary medical test, treatment, and procedures can help us with the efficient, cost-efficient manner. Implementing non-evidence-based practices such as N-acetyl cysteine for prevention of contrast-induced acute kidney injury is costly and not even beneficial to a patient. And improvement in patient care, including outcomes such as acute kidney injury incidences, acute kidney injury severity, acute kidney injury to CKD progression prevention, and length of stay, as well as readmission. So to summarize this, drugs are estimated to be the third leading cause of acute kidney injury in critically ill patients. So we, as the clinicians, need to embrace the concept of nephrotoxin stewardship in order to ensure a structured and consistent approach to a safe use of medications and prevention of harm to the patient. So nephrotoxin stewardship requires a coordinated patient care management strategies for safe medication use, ensuring kidney health, and avoiding unnecessary cost to the patient. Thank you.
That was very good. I think let us invite any comments or discussion on this before we move to the next topic.
Yes, sir.
Any questions? Anything anybody has not understood in this part? I think it was quite self-explanatory. If everybody is comfortable and everybody has understood, then I think we can go to the next talk. Which biomarkers are available in India? I think they are all experimental for now. Only thing that is out the order of the day is cystatin C, which you mentioned. That is available, but other than that, even the NGL is not commercially available. And the values, even if you get them, the consistency is not so good.
You always keep. So do you have anything more to go on?
So I have this question regarding this therapies that are under investigations. Like
the phenoldopa was already been a pentoxifylline never worked. It has been tried in almost every your phosphodiesterase inhibitors like aminophylines were all given into the contrast induced, but again didn't work. So I think Rushi sir will agree with me and other nephrologist friends who are here that this is on contrast induced, right? So only debarring your good hydration, isosmolar contrast and minimizing the volume. These are the only three proven things that had worked.
Yeah, no, I'm in total agreement there, Arindam. None of them have stood the test of time. When I started my residency in nephrology, everybody used to get what was called as a renal dose dopamine. And several trials were done, and all of them showed a negative result. So ultimately, it was out the window. So all of these drugs, they came in with a lot of, bench promise, but when it was translated to the bedside, they did not show enough clinical evidence for us to continue using them. So as of today, nephrology stewardship, nephrotoxin stewardship is definitely the order of the day. It is better to prevent an AKI than to try and treat the AKI with all of this.
Sir, what do you think about this concept of nephrotoxin stewardship? Can we initiate and implement in individual institutions, starting with ours?
I think it's a very good concept, and definitely something that will see. Basically, it is like awareness more than anything.
Right, sir.
And if we just start this concept and we promote it, it makes people wonder why we are talking so much about something. So they go back and look, and then it's common sense. Whatever Avni just showed us, a lot of that is common sense.
Yes, sir.
It's not known, but still we commit the mistakes because we are not paying enough attention to the details. And
very well said, sir. I think that is the major way, that the more that we do, it would create more awareness, and people will always check their actions, whether those actions are contributing towards the general unwellness or ill health of the kidneys itself. Sorry, I interrupted you. Carry on.
No. A small thing like introducing when I requested our lab to start putting eGFR to every creatinine that is done in our hospital. Okay.
Yes, they have done that, sir. They're doing it.
Now, last 1 year, it has become like a routine.
Yes, sir.
And what is interesting is that, specialties like orthopedics and obs-gynae, they are looking at the eGFRs, and eGFRs less than 60, their antenna is up. They are like wanting to know whether they are doing the right thing. So I think spreading awareness definitely helps. And this concept is very interesting, and I think we should make a small start and see how it goes.
Okay, sir. Any other questions or anything? Any comment or any question? Or other friends who are here, let us see. Anyone? Vikrant, you want to say something? To see.
I think Prakash has joined from Kolhapur. Hi, Prakash.
Prakash ji has joined.
That's good. Okay, I think this is good because it's bringing people together also. So I think we should continue.
Hi, sir. Hello, sir. Good evening.
Hi, good evening, Prakash. How are you?
Yeah, fine, sir.
I'm happy to see you here. Thanks.
Yeah. I'm happy to hear you after so long time.
Sure.
Yeah.
So, is the second speaker ready, Arindam?
Second speaker, but Prakash ji wants to speak anything and any comment?
Sir, I will go ahead, sir. I'll ask something later.
So, Avni, do you want to conclude or we move to the second speaker? Okay, so Reshma, kindly, you can, if you are ready with your A, you can start. The second one is mostly our Reshma Shetty, the critical care nephrology fellow. So she is going to speak on certain changing concepts in AKI. Particularly, she would be speaking on subphenotypes and how different subphenotypes are now identified, and what is the concept of predictive and prognostic enrichment, and how, if we can identify a certain subphenotypes, whether that could be a different phenotypes can have a different prognosis as well as therapy. So individualized therapy. So that means not all AKIs fall in, causes of AKI fall into similar methodology or etiopathophysiciology. It could have different types of pathophysiology, but more importantly, that identification of subphenotypes may have implications on choosing individualistic therapy. So it is more moving towards a concept of precision medicine or individualized medicine, the way it has done wonders in oncology. So whether it is time that nephrology, particularly AKI, can have certain implications. So we will ponder on this subject later on in more details. I will ask our nephrologist friends to also present in more detail. But today, as we are in the beginning of our CCN overall understanding, this is just we have started the second batch. So slowly and gradually, we'll move up into more details and more complexities. So over to you, Reshma. You start, please.
Thank you, sir. I would just be speaking on the changing concepts in AKI. Next slide, please. So acute kidney injury, which was previously named as acute renal failure, it's a complex clinical disorder. In that, there's loss of kidney's excretory function, which usually occurs over the course of hours to days, but it's often with oliguria. So this is seen commonly in hospitalized patients, especially in critically ill patients. Next slide. AKI includes various etiologies like ATN, pre-renal azotemia, acute interstitial nephritis, glomerular or vasculitic renal diseases, post-renal obstructive nephropathy. So some of these conditions may coexist in the same patient, and many patients remain dialysis dependent or they are left with severe renal impairment. So it is since it is associated with severe morbidity and mortality, so this is it's very important to look over it. Next slide. Sorry, the previous slide, please. So along with this AKI, we need to understand that we increase the hospital stay of the patient and eventually the overall cost that it costs the patient because of the severe morbidity associated with it. So all preventive measures should be taken to avoid this burden of this AKI, but usually it is overlooked. So there is this ischemic cascade that occurs. Next slide. Where there is impaired renal blood flow, which leads to hypoxic injury to the renal tubular cells. So hence it disrupts the intracellular calcium homeostasis, depletes the intracellular ATP, injures the endothelium, and eventually releases the cytokines. So in this, there is this activation of all the three systems. That is the renin-angiotensin aldosterone system, renal sympathetic system, and the tubulo-glomerular feedback system. So all these induce renal vasoconstriction and eventually lead to increased release of vasopressin. So that contributes to water retention. So there is this different phases of AKI development and progression, which is been shown in this table. There is this patients who are at risk. Initially, there is this subclinical AKI staged as per stage 1, stage 2, stage 3. This is staging as per and acute kidney disorders. So this staging and KDIGO guideline, the creatinine and urine output, but this has been first scored. So like I was talking about, so AKI is defined as, it depends on the creatinine and urine output levels, and the duration is less than or equal to 7 days. but it is also a part of the acute kidney diseases and disorders. That's the AKD. CKD describes us that there's persistent alteration of the kidney function, which is more than 3 months. And both AKI and AKD can occur in patients with or without precedent CKD. And NKD is a term that is no kidney disease. So this terminology does not overlap with any of these entities. So this is also a depending classification upon the duration and your creatinine and urine output and the biomarkers. Next slide. So there are various causes of AKI. Next slide, please. So serum concentration of the creatinine and plasma urea, they are insensitive markers of GFR. Now they are modified by nutrition, GI bleeding, steroids, high protein diet, muscle mass, age, gender, and aggressive fluid resuscitation. So due to these limitations of creatinine, it's not an ideal marker for renal function. But however, it is highly associated with the outcome in patients with AKI. So several other biomarkers, as mentioned earlier, that is cystatin C and NGAL, they have been suggested for the diagnosis, severity classification, and most importantly, the modification of outcome in AKI. So what are these causes of AKI? It is divided into pre-renal, intrarenal, and post-renal causes. So in pre-renal causes, where we can see impaired renal perfusion, like as in cardiorenal syndrome, shock, which includes hemorrhagic shock, hypovolemic shock, and septic shock, abdominal compartment syndrome, and a kidney transplant patient, which includes delayed graft function, medications such as ACE inhibitors and ARBs. These are included in the pre-renal causes. In intrarenal causes, there can be thrombotic microangiopathies, sickle cell anemia and sepsis, systemic infections and sepsis, pyelonephritis, drug-related tubular necrosis or heavy metal-related tubular necrosis, then rhabdomyolysis, monoclonal gammopathies, acute interstitial nephritis, and acute cellular rejection. Post-renal causes, that can be a urinary tract obstruction, which can occur at the level of either urethra, or there can be a bladder dysfunction. Next. Next slide. Common causes of AKI in ICU. That's the 5 most common causes of the same is sepsis, major surgery, low cardiac output, hypovolemia, and medications. Whereas other causes would be trauma, hepatorenal syndrome, CABG, abdominal compartment syndrome, rhabdomyolysis, and obstruction. This particularly in the ICU. Next slide. So here, next slide, please. So here in the next slide, we can see a simplified diagram where we can see that there are these factors like venous congestion, hyperperfusion, low cardiac output, or nephrotoxins, or damage and pathogen-associated molecular patterns, or some baseline risk factors. All these, this may cause this AKI and fall in the GFR, but few cases there can be a rapid reversal. But this, like we saw the classification earlier as per creatinine and urine output. So the subclinical AKIs or the initial stage of AKIs, that can be reversed with correcting the volume and renal perfusion. In some cases, if it progresses further to subclinical AKI, we can diagnose this with injury biomarkers. So if it progresses to tubular injury, then injury biomarkers, progression biomarkers, and other tests, this can, progression of the disease can be found out early. So eventually the outcome would be towards, if it worsens further, it would worsen either towards fibrosis or it may resolve. So there, even these, there are other kind of biomarkers. There are that is fibrosis related or CKD related that can help us classify or make us understand what the outcome would be, whether it would be a full recovery or they would progress towards CKD or end stage kidney disease. Next slide. So mild AKI, it is defined as a transient decline in urinary output or excretory function. It involves minimal kidney cell necrosis, or there may be necrosis. So nephron numbers may remain identical, but in long term, the risk of cardiovascular disease is somewhat increased. Then it can be whenever AKI associated with kidney cell or tubular necrosis, the affected cells are irreversibly lost during the phase of acute necroinflammation. This is what happens in moderate AKI. Nephrons in which the injured segments do not recover, they undergo atrophy and they are irreversibly lost and replaced by fibrous tissue. So the resulting hyperfiltration requires an increase in the functional capacity of remnant nephrons. So depending on the number of remnant nephrons, the capacity for adaptation, that is the kidney reserve, and the filtration load, which depends on the body weight, fluid intake, diet, and others, the GFR can return to baseline. So this status, it qualifies as the CKD, even if the GFR returns to baseline. And the adaptive changes of CKD imply a higher risk of cardiovascular disease and possibly irreversible loss of the nephrons. So whenever we have the severe AKI, it involves extensive tubular necrosis. Can we just go back to the previous slide, please? Yeah. So in severe AKI, there is extensive tubular necrosis, because of which the nephron numbers are substantially reduced. So the tubular recovery occurs only in those nephrons with surviving progenitor cells. So adaptation to the filtration and metabolic demands results in large increase in the dimensions of the few surviving nephrons. So such adaptations that may lead to secondary FSGS and subsequent loss of the remnant nephrons, and then eventually towards progressive CKD. Next slide, please. So AKD is defined as an AKI episode that lasts more than 7 days but less than 90 days. And it basically aims at closing the gap that is there between AKI and CKD. Because CKD would be loss of your renal function for almost 3 months. So it's important to note that the diagnosis of AKD, that's a severity, may be affected by the decrease of serum creatinine related to muscle mass loss associated with chronic critical illness. So the relationship between persistent AKI, AKD, CKD, as well as the interventions, it may interfere with this evolution and which eventually requires further studies. So hence, that is why furthermore several biomarkers are still being studied for this diagnosis, severity classification, and most importantly, the modification of outcome in acute kidney injury. Next slide. Now, certain biomarkers, they indicate early kidney injury or subclinical as a risk factor for proceeding to AKI. So AKI itself is indicated by injury markers in the blood and urine before any impairment of kidney function. So the 3 stages of AKI, they are defined by the extent of renal function impairment. Now, patients with this structural damage causing irreversible nephron loss, this does not, which does not occur, they may fully recover also. So AKI with structural damage frequently, which lasts more than 7 days, that is classified as AKD and the irreversible nephron loss, it precludes the restoration of the baseline GFR. Now that results in CKD or persistent kidney failure. Next slide. So this diagram would show how this AKI would affect the kidney lifespan. So the kidney lifespan, it depends on the individual endowment with nephrons. So the decline of nephron number and GFR with age can be expressed as declining percentiles, if you see, which is the blue line which is shown. So each irreversible nephron loss that is related to AKI reduces the kidney lifespan. So if you see at the younger age, the decline is quite slow compared to the one with a patient who is elderly. The decline is quite rapid. So the shortening of kidney lifespan implies the occurrence of kidney failure many years earlier, and at the worst, directly after the AKI episode. So severe AKI at an older age has a more immediate effect on the remaining kidney lifespan than at AKI at a younger age. Next slide. So this is the consequences. Why are we talking so much about AKI? So because of AKI, there can be fluid retention, which could cause fluid overload, lung injury, ARDS kind of picture, uremic encephalopathy, ischemic changes in the liver and the intestines, and also may affect the immune system. Next slide. So why are we talking about this AKI subphenotypes, and do we have any progress for personalizing the care? Next slide. Next. So while the current definition of AKI has enhanced this clinical recognition of the term, combining all patients into one group may hide the subgroups that are tightly linked to clinical outcomes. So supporting this notion, multiple research groups have shown that diversity within the AKI clinical syndrome exists, and one-size-fits-all approach may not be ideal. The efficacy of certain already tested pharmacotherapies may have been concealed by the existing heterogeneity in the trial population and lack of suitable measures to detect the improved outcomes. Next. So a subphenotype, it's a distinct group of patients within a phenotype. Such as AKI patients, they may share common features, risk factors, biomarker positivity, response to the treatment, or the outcomes. So this will separate the subphenotype from other group of patients within the phenotype. So thus, there are multiple ways to classify these patients. So there is this severity scoring, which is according to the clinical features, and hence that's how it is subclassified into stage 1, 2, 3, and subclinical AKI, AKD. So there is this previous practice that we had this stage 1 to stage 3 AKI that we classify, but that is as per creatinine rise. Like we discussed earlier that creatinine may not be an ideal marker because it is affected by a lot of factors. So however, classifying these patients using multiple clinical variables and biomarkers to more specific biological subphenotypes may better reflect the underlying pathophysiology, and hence we can have this customized approach to a care and have targeted therapies. Next. So regardless of the strategy used to subphenotype AKI, the overarching goal should remain the same. That is to cohort the patients into groups with unique prognostic or therapeutic implications, So subgrouping patients in this manner is termed as enrichment. So there is this a schematic presentation of how subphenotyping can facilitate prognostic enrichment and have predictive enrichment. So prognostic enrichment is something that identifying patients likely to have a disease-related outcome of interest. Whereas predictive enrichment is selecting patients who are more likely to respond to a given therapy on the basis of the biology. So that's how we'll personalize this AKI management. So whether they need early renal replacement therapy or not. So that is the prognostic part, and the predictive will be depending on the biological response to the therapy. Next. So the concept of pre-renal, intrinsic, and post-renal AKI was earlier used to stratify this etiology. As a diagnosis of AKI does not account for the etiology, the diagnostic tools. So the conventional tools, it may reveal the disease process with specific treatment. So the conditions like thrombotic microangiopathies, glomerulonephritis, or post-renal obstruction. So in addition to these, using the creatinine trajectories may allow a more tailored and immediate approach to the management. So here we can see 4 kind of phenotypes. That is in the A group, where there is transient hypotension and hypovolemia, the way the creatinine trajectory is there in the diagram. Then in contrast, associated AKI and sustained hypotension, or if the hypovolemia that has been just reversed. So in B, whereas in the day 7 or 10, the creatinine has a rise, but once the reason is corrected, there is a smooth decline, and pre-discharge the creatinine comes somewhere to normal. Whereas in phenotype C, that is hepatorenal syndrome, or a patient is in persistent shock, there is this rise of creatinine, but which persists to be on the higher side even when it is more than maybe 2 weeks. And phenotype D, if you see, that's a hospital-acquired AKI, which initially until 1 week, 10 days, it's normal. But later on, due to some reason, the patient develops AKI. So at the end, there is a steep rise of the creatinine. Next slide. So this is these are another patient scenarios that is depicted in the diagram with this creatinine, different trajectories that they have shown with the rise of creatinine. Next. So this is a map of standardized values of each variable by AKI subphenotype. So this is for 2 kind of groups. That's the discovery and replication groups. So these variables are sorted based on the degree of separation between the AKI subphenotypes. So from maximum values with the AKI at the top to maximum values of maximum to minimum values. So these variables were standardized by scaling all means to 0 with standard deviation of 1. So a variable of 11 for the standardized variable signifies that the mean value for a given AKI subphenotype was an entire standard deviation higher than the mean value for the population as a whole in that group. Next slide. So you can see various etiology or risk factors. The subjects where we can consider the demographics, that is the age, gender, race, what comorbidities the patient has. In case of ICU events, whether there is NORAD requirement, thrombocytopenia, acidosis, low urine output, in lab values, they've taken into consideration about the creatinine, then other biomarkers, whatever present. So as per that, they have classified into these subphenotypes. Next. So there was this abstract where the study of it was to identify and test whether these AKI subphenotypes have prognostic and therapeutic implications. So currently there was no safe and effective pharmacologically interventions which existed for AKI. So they concluded by saying that this analysis identified 2 distinct AKI subphenotypes with different clinical outcomes and their response to vasopressin therapy. So identification of AKI subphenotypes could improve risk prognostication and may be useful for predictive enrichment in clinical trials. Next. So fluid management in AKI, this is what is depicted in this diagrammatic presentation. So both hypovolemia and hypervolemia, both can compromise the kidney function, and impaired cardiac function can add on to these problems. So hence it is called as, since they can, renal and cardiac dysfunction can aggravate each other. So hence it is referred to as cardiorenal syndromes. So an injured kidney or heart, it will increase the likelihood of developing clinical symptoms of hypovolemia or hypervolemia compared with healthy organs. So hypotension frequently indicates kidney hypoperfusion despite clinically apparent hypervolemia. Whenever the fluid redistributes to the venous system into the tissue interstitium or third compartments. For example, like in HRS or sepsis or CCF. The kidney or heart failure drastically decreases the organ's capacity to maintain the function during hypovolemia or hypervolemia. So in an apparently euvolemic patient with AKI, a single bolus of crystalloid fluid can indicate the presence of subclinical hypovolemia and hypoperfusion of the kidney. Prolonged administration of balanced crystalloids should be handled with caution in order not to promote the edema or congestion, not to decrease the tissue oxygenation. So patients with hypovolemia should not receive fluids for AKI, but rather loop natriuretics. And critically ill patients with suppressed vasomotor response, so they would require vasopressors frequently to improve the cardiac output. Next. So again, a diagram which shows where we can identify the risk factors, the injury, where we can monitor the kidney function, where the kidney has an injury, and eventually what are the outcomes. So as per this classification, when this kidney insult is occurred, so we can actually have these phases of primary prevention. With the help of biomarkers, we can identify early, so we can go in for secondary prevention, and also give a thought about whether this patient requires early replacement therapy or not, whether that would help in improving his outcome. Next. So the complications, so basically the target is that with this early identification with these different kind of biomarkers, we sort of early diagnose the further worsening of kidney function, and we help the patients not to become dialysis dependent or progress towards CKD or ESRD. Next. So we first have this clinical recognition where we try to understand whether there is, what is the etiology, whether there is actual tissue damage, what is the timing of the injury that has happened, will this patient respond to the treatment, or whether there is an established, if there is an established injury, or whether there is ongoing injury, for how long it is occurring, and risk of complications. So the questions that come to our mind would be that whether my patient will recover from this AKI, how long would it take, whether he would further go to the, subset of progressive CKD, and how would we manage further. So how these biomarkers would help eventually, that's what we need to look into. So it will basically allow for detection of the early injury or the subclinical cases, and let us know about the location and underlying etiology. What is the extent of damage, and whether there's risk of further loss of the kidney function, whether there is an ongoing injury. It will provide information on the prognosis and recovery, and subsequently the outcome. Next. So there are a list of biomarkers, like we had enumerated earlier also. Even Dr. Agni had mentioned about cystatin C, NGAL, IL-18. So there are these various biomarkers, and out of that, cystatin C is, like Sir said, is available right now, which would earlier help us to detect early the stage of AKI, and it's not dependent on the muscle mass. So next slide, please. So the nephrotoxic agents, Dr. Agni has already mentioned about this. I'll not go into details of this. Next slide. Next slide. This is again about nephrotoxin stewardship, which we have already discussed. Next, please. So stage-based management of AKI. So we discontinue all the nephrotoxic agents whenever possible. We try to ensure the volume status and perfusion pressure. We consider functional hemodynamic monitoring and monitor the creatinine and urine output, and also consider alternatives to the radio contrast procedure. Non-invasive or invasive diagnostic workup is what we need to look into when we progress further into stage 2 of AKI. Also, in case of RRTs, we need to, or worsening of AKI, we need to check for the changes in the drug dosing. And that's all. Next slide, please. So what does not work in preventing AKI? So there's this evidence-based statements that we have a list of, that diuretics to prevent AKI, but then that depends on the volume status of the patients. So diuretics to treat AKI except in the management of volume overload. Low dose dopamine to prevent or treat AKI does not work. Phenol-dopam also is not the choice. Aminoglycosides for the treatment of various infections, until unless, depending on the sensitivity, since it is a nephrotoxic drug, we need to think of therapeutic alternatives for the same. Next. So not using NAC to prevent AKI in critically ill patients with hypertension. So oral or IV NAC for prevention of post-surgical AKI, oral fluids alone in patients at increased risk of contrast-induced AKI. So these all wouldn't work in preventing AKI is the thing. And prophylactic intermittent hemodialysis or hemofiltration for contrast media removal in patients at increased risk for contrast-induced nephropathy. And diuretics to enhance the kidney function recovery or to reduce the duration or frequency of renal replacement therapy. Next slide. So if AKI is present, we need to first see the intravascular volume and optimize the resuscitation. If there is AKI severity as per the creatinine trajectory, so the initial and there is initial response to the volume bolus. So then, despite that, if it further progresses to severe AKI or mild or moderate, then accordingly we need to think about considering early RRT for these patients. If AKI is not present, then we need to see other indications like refractory fluid overload, refractory septic shock, acute liver failure, tumor lysis syndrome. It can happen in severe electrolyte disturbances because of AKI, and particular toxins. So there also we need to consider adjuvant role of RRT and also monitor the clinical status. Next slide. So there was this paper which mentioned about this dilate trauma concept. This is about handling CRRT patients where they had noted adverse effects of CRRT in ICU patients. Next slide. So they had tried, there was this physician, Maynard Molina, who had coined this terminology, dilate trauma. And they had tried to integrate several complications of high-dose RRT in ICU patients. So these consist of arterial hypotension, metabolic-wise, that is the electrolyte imbalances, hemorrhagic complications, infectious complications, hypothermia, and drug dosing abnormalities. Next. So the factors that affect the pharmacokinetics while on a renal replacement therapy are protein binding, size of the drug molecule, and the mode of RRT, what kind of filter is being used, timing of the RRT, that is intermittent versus continuous.
Can I just interrupt you for a minute?
Yes, sir.
I think this is just too much information for one go. Okay. I think the topic today was what?
Subphenotypes, sir.
Exactly. So let us focus on, summarize on those parts because this is for another day.
Okay. Okay.
So please summarize that part. Because that is a very interesting concept, like the nephrotoxins. It is a new concept, and that's why Arindam gave it to you. So this particular part, I think you can take it the next time forward. Okay. Just summarize that part and let's have a discussion before we close. We are already 18 minutes ahead of schedule.
I think this is it was more of that these are the concepts. We will cover it in the subsequent lectures. And drug, particularly this one, the pharmacokinetics and dynamics in renal replacement therapy, this is itself will require a couple of classes for intermittent and all that. So I think we will
let us summarize.
sit down. Yes,
let us summarize those 2 slides where she tried to give us the concepts, the new concept of AKI as well as this phenotypes.
Sir, I would ask you to, if you please, because you have...
summarize, na? Let us summarize.
Yes. So I would ask you to summarize, sir, because you have so much of knowledge, core knowledge on the... Okay. Reshma, can you kindly summarize and then Rushiji will take over?
Yes, sir. So basically subphenotyping, it helps to differentiate the patients with these different pathophysiological mechanisms, severity of the illness, and the outcome amongst all patients with AKI. So clustering this data from these not routinely measured biomarkers, they have revealed these subphenotypes. So there is potentially distinct pathophysiology with response to, with regards to the response to inflammation. Hence, that is why there is a lot of research work that is going on for these biomarkers, and hence so that we can give targeted therapies for the same and identify earlier. So, like I told, from subclinical AKI for patients at risk, so we can identify them earlier and prevent or reduce the incidence of progression towards CKD or ESRD, and so that they don't become dialysis dependent and have better outcomes. And that's also.
So yeah, very well covered. Yeah. See, basically, what was interesting about this particular topic is the fact that you are looking at AKI in a new way. You are trying to say, okay, there are two types here. One, how am I going to detect this early? What can I do? So you are giving us a clinical scenario where clinical risk factor score to tell us, okay, this is the risk factor score. Your probability of having an AKI during your hospital stay is so-and-so. And the other is the markers. So the markers are your new tools. And as the markers become more commonly available and we learn to use them better, we'll be able to specifically say, okay, your AKI is because of this injury. And we may have therapies to treat them. As of today, we don't. But yes, in the future, that is where this is headed. That is why the intense work going on in this segment to try to understand the biomarkers. Sorry, somebody saying something? Okay. So basically, the work for finding the biomarkers, and I think the word precision, it is a very good word because it tells us that, okay, by doing these clinical and biochemical phenotyping, we'll arrive at a prediction, a predictive value, which has scientific rationale. You'll be able to accurately predict the chances of your patient having an AKI during your stay in the hospital, in the ICU or in the rooms. And hopefully you will have specifically directed, targeted therapies with minimum side effects to alleviate this injury. So I think this is where it is headed. So precision and nephrology, like Arindam said, is a work in progress for now. And this is the direction it is taking. And the other thing which Pritima covered, which Reshma covered very beautifully, was the newer way of looking at AKI and not just trying to club them into pre-renal, renal, post-renal, but the four newer ways of looking at AKI from the pathophysiological perspective and trying to say, okay, this is the pathophysiology and hence this is what you're going to expect clinically. So I think that was also a very important part of your talk today. So these two parts were particularly important. The rest of it, obviously, you had good slides, but these two parts are new and enticing, and we are going to hear a lot about them in the future. So with this, I think I'll open up the podium to whoever has any comments or questions to speak.
Sorry, one question from Chandrima is that whether N-acetylcysteine do work in CIN?
Sorry, I don't think I'm audible. Yeah, sorry.
Now you are.
There was this question in the chat that I did reply to. I think it went to a private message. So basically the part was that why do we use N-acetyl for prevention of contrast nephropathy when the evidence is not so crystal clear? So I think it is based on two reasons. A is the fact that the downside is very little in terms of expenses or side effects. And second is that there is one good randomized controlled trial, which is like a level 1 evidence. Even though there have been several trials after that that were to the contrary, and that we all know, because of these factors, I think we still tend to use an acetylcysteine. And that being said, I don't think it's a panacea. And when we use it, we know that, we are doing something, but how much it will help, we don't know.
Anything else, Ketan, you want to comment anything?
Can I comment?
Yes, please, Prakashji.
Rishi sir,
Yep.
this was interesting talk. There was very interesting models here. She has described the enrichment model and the predictive models and the phenotyping. It's good to listen to, because theoretically it sounds very scientific. But these things need to be elaborated in the form of examples, by actually putting the examples and actually phenotyping such patients and putting this into the enrichment models also. So how it can be practically applied, that's still a question. And also I want to comment that despite so many years, we still don't have any sensitive marker for AKI. AKI is like an AMI for us as a cardiologist has PROP-T and PROP-I, but we don't have such any biomarker despite so many years. The cystatin is definitely available, but we can't keep repeating it to check the trends because of the cost factor. And we know that as a nephrologist, we are usually called very late into the picture in a case of AKI unless the creatinine crosses beyond 3.
Yeah. So all of your points are well taken, Prakash. And these are practical problems faced by all of us in practice. And the answer to them is awareness. And that is what we are trying to do by setting up this specialty, because we believe that awareness will help in early detection, better management, and much better patient outcome. Ultimately, I think that is what we all strive for. And unless there is awareness, they are not going to tell you early. They are going to call you when there is an imminent dialysis need. So unless they realize that, you need to risk stratify, you need to phenotype, you need to look at it from the clinical and as these biochemical markers become more and more available, I mean, this is work in progress, right? I mean, when you were with me, there was no question of doing a DSA in a transplant patient.
Right.
There was no question of doing a flow cross match. Today, I don't do a single transplant without a flow cross match.
Yes.
So I think it is like that here also, where today we are saying that they are not being available clinically yet, but they will become available. I mean, look at our own things in membranous. There was no marker. Now you have 5 to 7 markers which are available as a panel for you.
Right.
So it is work in progress. And I think we need to be optimistic because people are doing their part. And we as clinicians need to do our part and spread the message. These things, in Kolhapur, if you start doing something like this with your physicians, I'm sure it will be taken nicely. And you could ask them to join here, or, you could take them separately, whichever way you like. But unless they become more and more aware, they are going to always pick up things late. It's not that they don't know. It's just that because they are not so aware, they are not looking for it actively.
Yeah, right.
So Prakash was with me in 2008, right, Prakash? 2008-9. That's when you started?
Yeah, 2009.
Right. Any other comments? Anyone? Okay.
Sure.
So basically, I think the take home is here, as rightly said by both of you, that we have to understand the phenotypes of these patients. And from education point of view, of course, every case is different and the presentation is different. And biomarkers, we yet to have whatever we have, we at least should use and understand the real practice, the use in our clinical practice. Well, there are many, but really there are very few which are easily available and doable. So I think thank you everyone. Thank you Reshma for the presentation, and I think we'll continue this for the next session also.
Avni, Ketan. Avni also had a very good presentation on
Avni. Avni. Yeah.
Thank you.
Yeah.
Okay, thank you.
You.
Bye bye.
Yeah, thank you. Goodbye. Bye.
Bye.
Thank you, sir.